So we'll move on to our next presentation. We have a team presentation next. I'd like to introduce Dr. Tracy Tay, who is the clinical lead with the Agency for Clinical Innovation and also works in innovation support at Hunter New England. She's going to share a story about teamwork and a whole of system approach coming out of New Zealand and applied locally in our own system and share some of the learnings and some of the benefits of that approach. So thank you, Tracy.
Thanks, Nigel. That's all right. Save your applause for the real speakers. First of all, can I add my respects to the elders of the Eora Nation, the traditional custodians of the land. Now, transformation is obviously, and innovation occurs everywhere from the molecular level to the whole of system level. And I know that there's a lot of people in the room and across Australia who have been inspired by some of the work happening in Hunter New England Local Health District around a program called Health Pathways. And we thought it was really important to make sure that, that you all understood where that inspiration came from. So I'm very, very excited to be able to introduce Carolyn, who has come over from New Zealand to speak, who's the General Manager for Planning and Funding for the Canterbury District Health Board and for the West Coast District Health Board. Carolyn and her team of clinicians have been responsible for a very exciting and successful program called the Canterbury Initiative and Health Pathways, which are based around the Christchurch region. And every now and then, you can be lucky enough, as we were in Hunter New England, to come across an idea that really changes your thinking and inspires you to act very differently. So the Canterbury Initiative and Health Pathways have done this in two ways, I believe. So firstly, they've shown that doctors, nurses, allied health staff and managers from across primary, community and acute care can connect the care they provide to the patients that they share. And that wonderful things can result. Secondly, and very importantly, through Carolyn's leadership, we can see what's possible when managers have a very strong and compelling vision, when they trust and support their clinicians, and when those clinicians step up to share accountability for improving health outcomes, for improving the experience of care for patients, and for controlling costs. So thank you for coming all this way, Carolyn. I'm sure you'll enjoy this presentation.
Thank you, and thank you very much for inviting me. And Minister, I appreciate your vision for having a conference like this. I think it's a fabulous idea. And thank you to my colleagues in Hunter New England who've taken our idea and taken it to the next level. I'm going to tell you a story about how you transform a health system. But just quickly, just what is a district health board, which is my role as General Manager of Planning and Funding. There's 20 district health boards in New Zealand. We plan, fund and deliver services all the way from health, home-based support services to cardiothoracic surgery. Canterbury is one of the biggest DHBs in New Zealand. It has a population of about 500,000. We're what we call capitated, so we get our funding based on the size of our population. We own and deliver the secondary and tertiary services, and we fund the rest of the health system. Like you, we had a burning platform. We had a fragmented system. We had a system that was driven by contracts and transactions and people's belief about financial incentives driving change. South Island in New Zealand is at the leading edge of the demographic wave. Currently, 1 in 5 people are over the age of 65. By 2026, it will be 1 in 3. Canterbury is the only district health board in the South Island that's going to have an increase in the people under the age of 60. Every other district health board in the South Island is going to see a decline in that population as well. So we're all looking at an issue. Growing demand, growing admissions in our hospitals, growing waiting times. If we'd kept on going on the path that we were on when we had a look at this in 2007, we would have needed another hospital the same size as the one we already had. 20% more GPs, and the average age of general practice in New Zealand is 53. So by 2020, don't know that we'll have 20% more. And aged residential care, which we also fund, was growing at a rate that would have meant by 2020 we would have needed another 2,000 beds. So clearly a burning platform. If you add all of that up, it would have meant that by 2020 we needed another 6,000 people in the workforce. We didn't see where they were coming from. We did think that maybe by the time we got there, that if you wanted a place in a rest home, you might need to be a retired nurse who was willing to do the medication round. However, the oldest working nurse in 2007 when we started telling this story was 81. So together in Canterbury, we learned how to transform a system. And how did we do it? We had a shared vision. And yes, we do have that picture, and if you go to Canterbury, you will see it all over the place. It's about a connected system, a system that's centred around people, that aims not to waste their time. Sometimes you have to be quite clear about the goal is. The goal of our system is to keep people well and healthy and in their own home, but to do it in a way that doesn't waste their time waiting for the next step in their journey. We set 3 strategic goals in 2007 and we have stuck to them. It's about building a system that enables people to look after their own health. It's about building a health system that builds primary and community capacity and capability so people can look after themselves in their own home, in their own space and in their own communities. And using general practice for most people most of the time is that single point of continuity. So you have to think about how you organise your system around that. And it's about releasing scarce secondary care and specialist-based resources to do the complex stuff, to do the episodic stuff, and to support primary and community care. So it's based on the premise that you shouldn't be in a hospital if you don't need a hospital. And we developed a new way of working. We called it the Canterbury way of working because actually Canterbury's a bit parochial. But essentially the way it is and this is the transformational leap. It was all about building an innovative, capable health system with everyone having the permission to make it better. And it's not a single big bang. We didn't do a big, huge IT strategy and we didn't come up with a big, detailed plan. But it was a big leap. It was a big leap in how you think. You can't leap a chasm one step at a time. So it wasn't about incremental change. It was about changing the entire focus of a system, recognising that there was only one system. There is only one health system and there is only one budget. And the key measure in that system is not wasting people's time. And the DHB's job was to plan and organise and resource the system, but clinicians need to be enabled to do the right thing. And the DHB had to get out of the way. It's about people and it's not about money. We were actually in deficit when we started this program, and so it couldn't have been about money. And it's about a belief that most people will do the right thing if the system enables them. We had a whole series of initiatives and they've all been lined up, and we've been fortunate enough to have a long run at this. But it doesn't mean that you actually need 5 years to drive this transformation, because some of this was pathfinding and understanding how we needed to work. We used things such as lean thinking to improve the patient journey, improve productivity. We used processes like Seeing 2020 to develop that shared vision that we all believed in. We used processes like we planned the health system, but we went to our board and said, just ignore this document that is this thick, because tomorrow it will be wrong. Just sign off on the principles and the direction, and we'll do the rest. We had developed the Canterbury Initiative. We developed the Canterbury Clinical Network, which I'll come back to in a minute, and the electronic request management system. All of these were done by us, for us, as an iterative process, and all of it clinician-led. So these are the key enablers we designed in our system, because when we had that big vision, we said we needed a system that was so seamless that actually nobody knew who worked for whom. But the pathway that the patients followed was reliable. So we developed the Canterbury Initiative, which was all about primary and secondary care integration. And one of the tools that came out of that was health pathways. Now, we didn't go into this to design a website. In fact, we didn't go into this to do anything on that basis. But what happened was, when we got clinicians in the room and they came up with a better way of working, we needed somewhere to put the answer in a way that people could actually easily see it. So we came up with Health Pathways. Now, Health Pathways is a website. It's an interactive website. The value of Health Pathways is it's not a bunch of guidelines. It's actually how we have all collectively agreed patients will be taken care of in Canterbury, in Otago, in Timaru, wherever Health Pathways in Hunter, New England, wherever Health Pathways has been set up. It's based on evidence and judgment and the constraints the system has. It's based on the belief that all of us together are more wise than any one of us alone. So Health Pathways is live and the feedback keeps coming and we constantly make it better. It's a community of clinicians designing the system with the confidence that we will back them. That if they come up with a new pathway and a new way of doing things, we'll organise the system to make it work. So, as I said, a very simple website. We now have 610 pathways. We started in 2008. We get about 75,000 hits a month on this website, so I actually think people use it. And what we did post the major disaster we had in New Zealand was develop a companion website, Health Info for Patients. Because what we actually found out is that by getting everybody in Canterbury to agree that this was the way we were going to look after people on their journey between primary and secondary care, it was actually really easy to agree what information you were going to give patients about that. And that means we could get rid of all of those pamphlets and all of that other stuff and some of that outdated information that people provided, and therefore focus on the information that patients needed. We also supported this process with an electronic, we now call it an electronic request management system, because we don't refer people around our system, we transfer care between parts and we ask people for help and support. The difference about this system is that it's designed to work from general practice to anywhere in the health system, be it the private sector, the public sector, pharmacy, district nursing, anything you can think of. And it all goes through a single database. And here you come back to my passion for data and planning. That database collects all of those referrals, so then we know what people are referring for. We know what we can do, we know what we don't do, we know what we reject, and we know what we accept. And we know what capacity we're going to need in the future. So since we launched that, which was towards the end of last year, we've had 90,000 referrals through that, from the primary care sector into the systems in the secondary care sector. What we've also done is developed e-shared care record view, working with Orion. This enables clinicians anywhere in the system, because if you think about a system, anywhere in the system to actually go through Concerto and see what the pharmacist knows about that person, what the GP knows about that person, what the district nurse knows about that person, and what the hospital knows about that person. So that tells you a snapshot of the history of that person who's in front of you now. What collaborative care program does is the opposite. It tells you how you can all work together as a team to plan that person's future. So we've got the history, we've got the future, and we have a way of working together. Primary and secondary care integration and the Canterbury Clinical Network. The Canterbury Clinical Network is the organising infrastructure that we've developed behind it. We borrowed that from the construction industry. It's an alliance framework, much like the alliance framework that Australia has developed really, really well in the construction industry here. We borrowed it, twisted it, made it work in a health policy environment, and it sets up our contractual framework that says we all work for the same health system, we all know what the resources are, it's all open and transparent, and our job is to make decisions on the basis of what's best for patient and what's best for system. And it's clinically led decision making. And the job of my team is to make it happen. So, sounds like a good story, but did it work? As I said, we started from the basis of a deficit, and we started from a basis of a system that wasn't performing particularly well. Now we have a system that delivers more urgent care in the community. So we have an acute demand management program in our system which is designed to look after people instead of taking them to hospital. 21,000 episodes per annum. People spend more time in our 24-hour surgery in the weekends than they do in our ED, despite the fact they have to pay, because people have got used to that's how you get care. What that actually means for us is that we have reduced the number of people turning up in our ED dramatically, by about 13%. We've reduced the number of acute medical admissions, and we've reduced how long they stay there. We have a new program that we invented very rapidly in 3 weeks after the quake, which is about how to look after people post their discharge, particularly frail elderly people, keep them at home, rehabilitate them, get them back on their feet, make sure that they're actually as recovered as we can make them, so they don't end up back in our acute hospital and they also don't end up in aged residential care. And what that's meant, that group of people, the 60 to 80-year-olds, are spending less time in our hospital, which is just as well, because we lost 106 beds post the quake, so we had to get cleverer at this. What it means is, compared to the rest of the country, we've got about 70% of the acute medical admissions that the rest of the country has, and about 40% less than the other big DHBs. We have a lower readmission rate, and we have a lower average length of stay. This is in a population that's actually, on average, older. And that means if we were looking after our patients in the same way as the rest of the country is in New Zealand, we'd need another 1 to 7 additional wards in our hospital, which, as I said, just as well, because we lost quite a bit in the quake. And what it's also meant is, because we've got cleverer and better at not having people acutely unwell in our hospital, we've got more time to do the electives. So we've got more time to focus on doing the stuff that we can do in a planned way instead of the stuff that we do acutely. And the whole process around health pathways, it's made sure that people are only getting into our hospital when they need to be in our hospital, means that we've reduced the waiting times. So, for example, skin lesions, which is one of the first ones, and like you, we have a high rate of melanoma. Going into this program, we had a 9-month waiting list for skin lesion removal that was completely undifferentiated. So you could have had melanoma, but we didn't know. We now have 53 days as our average wait for removal of skin lesions from 9 months. And how about gynecology? That was one of our first off-the-rank ones, because they were keen to make it work. That was a classic example of where the funding and the funding mechanisms drive you entirely to the wrong answer. So if you look at that bottom line, patients were being referred from their general practice to the hospital would see them after a wait and then say, no, you need a pelvic ultrasound. They would refer them for a pelvic ultrasound, and then they'd go back and see their specialist again after a wait. And then the specialist say, no, actually, we need to do a papal biopsy. So they get their papal biopsy, and then they go back and see the specialist again after a wait. And then, if it was appropriate, they might get surgery. Now, they go and see their GP. They get that ultrasound within 2 weeks, free, provided in the community. If they need a papal biopsy, the GP does it. If they need some treatment like a Mirena or other types of treatment, it's delivered by their general practice. The hospital never sees those people. The only ones that get to the hospital are the ones that have to get there, because that's their next option is surgical. So what that means is we get less specialist assessments in our hospital because only the right people get there. It also means that the conversion rate from seeing a specialist to getting surgery goes up. So only the right people get in front of a specialist and the right people get surgery. And the number of referrals that get rejected goes down. So you don't have that horrible process of writing a letter to a hospital that gets bounced back at you. One of the measures that I mentioned at the beginning of all of this was people in aged residential care. So we firmly believe that if we could get the whole system to work, that we could actually keep people well and healthy and in their own home. So what we've shown is a reduction in the number of people ending up in rest home care and a reduction in the number of days that people spend in rest home care. What that does for our system is not only are we thinking it's the right answer for people, it actually also reduces the cost of the system. So that actual change in number of bed days in rest home level care saved us about $8 million in 1 year, which is $8 million which we can then reinvest. But for us, it wasn't about the money. It was about people staying well and healthy and in their own home. And under fire, under the biggest natural disaster that New Zealand has ever seen, this system worked. Within hours, we had the entire health system connected. By the end of the second day, we had free primary care across the entire health system. We had free access to pharmaceuticals enabled across the entire health system. We were evacuating people out of rest homes. The entire system was connected and working, and the people in Canterbury got ongoing health care. The health response was highlighted by our government as being an example for the rest of the country to follow. And one of the things they pointed out in that report was that the primary secondary care integration in Canterbury was one of the reasons the health system worked. We all knew how to work together, and we did work together. One of the interesting things about how we've made this all work is it's actually about all of us. It's not about a small group of experts in a corner coming up with the right answer and telling everybody that's how it needs to work. We've had hundreds of GPs involved in writing pathways, and we've had hundreds of specialists. It's not my program, it's our program. It's together that we have actually made all of this happen. And that's actually how we've managed to deliver a patient-centred system. It's not perfect, it's got a long way to go, and there's a huge amount more we can do and learn and gain, which is why I'm so excited to be here today. But it's about a whole system, and it's based on the premise that for a whole system to work, you need the whole system working. It's not about islands of excellence in the midst of chaos. It's about an integrated system. Thank you.
Thanks very much, Carolyn. I'm sure you can see why Hunter New England's been inspired to start this work. But it would be easy, and there may be some of you who think that the New Zealand health system is just too different from ours in Australia. It's easy to excuse our patchy integration of primary and acute care on the basis of our funding models. But our next speaker, Dr. Margaret Lynch, will give you a brief overview of how the way of working in Canterbury has inspired the work in Hunter New England. So Margaret is a GP, a clinical director at the Hunter Medicare Local, and also GP clinical lead for innovation support in Hunter New England Local Health District. Thanks, Margaret.
I don't have a lot of time, so I'll probably just whiz through some of the slides that I'll put up. Carolyn has really, I think, illustrated what did inspire us largely, and we've really just copied from what's happened in Canterbury in Hunter New England. And to start with, it's been limited to the sort of lower Hunter and the urban end of the Hunter New England region, but the idea is that we would like to expand it to the huge area that the Hunter New England Local Health District and the Hunter Medicare Local cover, but we had to start somewhere. So we have tried to replicate the Health Pathways program in Newcastle, Lake Macquarie and Maitland. It really is, we've put in place, by copying how they did it in Canterbury and Christchurch, the mechanisms for GPs, specialists, allied health across both the public and the private sectors to meet together and agree on pathways of care for different clinical conditions, which will work in the local context. There's a sort of a set format, short time frame. We facilitate meetings, face-to-face meetings between these groups or small groups of clinicians, usually based on a clinical condition or clinical area, and they meet usually perhaps 3 times over a 2 to 3 month period, and at the end of that period the agreement that they've come to about how care should be delivered for that particular condition is documented in a written pathway, which is then put onto our Health Pathways website, which is we're trying to make that the sort of go-to place for information, particularly for GPs, and that they can access the information they need about how to best assess, manage and refer patients at the time that they're seeing the patient, while the person's in front of them within a consultation. And we could obviously see the potential for this information to underpin more efficient electronic communications in the way that Carolyn was describing. And again, it's a whole of system change. It's a different way of working, including, we're kind of making it a bit of propaganda that, we want GPs to be as kind of dependent on our Health Pathways website and using it in the same way that they're sort of reliant on their clinical software in their day-to-day work. And I think we've got some evidence to show that that's starting to happen. We have a local version of Health Health Pathways website, which looks very similar to the Canterbury one. What have we achieved? Well, so far, we've had 210 clinicians directly involved in coming together and agreeing on pathways over the past 12 months. And we've actually had hundreds more clinicians involved in the wider consultation on these pathways. So it's just, it really is integrating everybody. It's fantastic. Are people actually using the site? Yes, they are. We've had, I think we're up to about 12,000 page hits a month now, and that's, you can see there's just a really steep increase in use of the website, and people are spending on average around 5 to 6 minutes on the site at a time. We're still fairly early on in our journey, so we have some preliminary data, particularly in maternity services at John Hunter, where we've decreased waiting times. So the pathway teams agreed that, you know, there's limited specialist resources, huge demand. The specialists should be seeing complex pregnant women. They should not be spending their time dealing with low-risk women who don't really need to be there. And GPs were more than happy to be providing that care. And so what has happened over 6 months, maternity pathways were some of the first ones to go up on our website and be sort of promoted, and there was a lot of education of GPs around these pathways. We've virtually eliminated the waiting time for access to antenatal services at John Hunter, and that means that the higher risk women are able to access specialist services when they need to now, and that we know that wasn't happening before, and that there's been a lot of redesign that's accompanied this, and that's part of the process. It's not getting people together actually helps them identify opportunities for redesign. We're also looking at things like, are we improving the quality of information that's coming into the system in terms of what's included in referrals when they come into particularly the public system. We've got some baseline information about that, and we will be planning to re-measure that down the track to see if Health Pathways is having the effect we think it's going to have. Just quickly, I guess, this started from the GP point of view because Innovation Support at Hunter New England actually came to what was then the Division of General Practice and said, you know, how do you think we might be able to work together to look at addressing some of the issues with the ambulatory care services in the Royal Newcastle Centre at John Hunter. A lot of background work had been done on within Hunter New England about what the principles of care should be for patients, and it is all about that patient-centredness, and you know really fits with the nice sort of diagrams that Carolyn showed us. We'd also surveyed GPs about their issues with the system and what they thought might be able to be done, and Innovation Support had identified that Canterbury had addressed these issues in a way that seemed like it might be a good fit with the Hunter New England problems. Graham McGeoch is a GP who is involved in leading this program in New Zealand, and he was just so inspirational. He came and spoke to us, and that was the other thing. And the other issue is that there's a lot of technical writing and IT support that goes into creating the website. That's one of the tools that we use, and that's being provided by Streamliners in New Zealand, run by a man called Ian Anderson, and they were pretty inspirational as well, and really showed us the potential of the electronic referral and electronic communication linkages that could flow with this. And particularly when the GPs in the room saw that, we just went, we want that and we want it now. And coincidentally, the Division of General Practice was transitioning to become a Medicare local, and we could see that this process or program really would give us the tools to achieve some of the goals that the Commonwealth had set for Medicare locals in terms of integration. It was a bit of an organic process, and I think we were lucky that we were kind of allowed to do it in this way, because we didn't know really exactly, we were kind of guessing about the resources that might be required to support this, and we were allowed to kind of make a start without really having to set absolutely firm targets and goals for achievement, and I think that was good. And it was driven by, I think, a lot of clinician enthusiasm, probably by GPs to start with, but then the specialists came on board as well. The other thing that's really made it work is that we had support very early on from the executive and board of both the Medicare local and the local health district, and there are smiling champions, Dr. Mark Foster, and who's the CEO of Hunter Medicare Local, and Michael D'Rienzo, the CEO of Hunter New England Local Health District. It was done on a bit of a shoestring budget to start with. There was a little bit of funding from Hunter New England through their Innovation Support Unit, and that mainly supported the work of streamliners in doing the technical writing and website support. The Medicare Local didn't actually have any funding for this, but we figured that a lot of the work we were doing actually assisted some existing programs, and we were able to sort of get some sideways funding from programs that were already in operation. But now we do have some funding from Commonwealth Flexible Funding to continue this program, because we can see that it is making a difference. And I think, as I said before, we were allowed to give it a go without really knowing what some of the outcomes were going to be. What have we learned? It's about developing and maintaining relationships. Clinicians need to lead the process and to feel ownership of the outcomes, and the pathways that have worked the best are the ones where GPs really have acted as the content owners and specialists are the subject experts, but it's got to work particularly for GPs. We've also learnt that, and I think we knew this from the New Zealand experience, that it's got to be, each local area needs to decide how it's going to work for them and what they need and how they want to do it. And even within our local area, we didn't realise that there's actually significant differences even between the City of Newcastle and the City of Maitland, which are a half-hour drive apart. And we thought we were doing what would work for Maitland, but we found out that perhaps it needs a little bit more tweaking and a bit more involvement from particularly, I guess, the specialist side in Maitland. Clinical nurse consultants are the major drivers of the process from the hospital and the community side, and they're often the main doers and coordinators of the teams. And I think that the teams that have worked the best have had the managers for the CNCs have allowed them some time to devote to this, and they're reaping the benefits of that now. And you can really see that in maternity services, I think, where a CNC's they've produced huge numbers of pathways, and it's been fantastic. We've in 12 months localised. We keep the New Zealand pathways and try to modify them where we can, or sometimes develop completely new ones. We have 60 live pathways on our site, and shortly to be 72, and that's in 12 months. So that's not a bad achievement, I think. We've also learnt that individual pathway teams need to be small, but they do need to consult widely. And that you really need to put a lot of effort in the beginning into peer-to-peer engagement. The GPs in our team have spent a lot of time going out and talking to GPs about this and why it's a good thing. And similarly, people from Innovation Support have mobilised the specialists in a similar way. Takes a lot of effort and probably more time than you think in the beginning, but it reaps rewards in the end. It's definitely a whole of system transformation, and you can't predict all of the outcomes at the beginning, and things kind of change over time. I think it is dependent on individuals and their enthusiasm, and I think there is the risk that people will find that hard to sustain in the long term. And I think we've sort of wonder whether that might happen a bit in New Zealand, because we know that Graham McGeoch is just he's amazing and he's done so much work, and it's we would like to be identifying the enthusiastic people early on and getting lots of them to be involved so we can sustain it. And the other thing I think that I just wanted to mention is that sometimes we start the process and we have to kind of stop for a while. We identify that some service providers really need to define what they can do, and they need to go away and think about that before coming back to the process, that we don't want to actually promote a pathway that doesn't work, because we want to keep the integrity of the process, make sure that people think that it is worthwhile using this process, that we need to act on feedback and communicate back with the people who are providing it, and the pathways really do have a great feedback mechanism built into them, and that evaluation and outcome measurement does need significant resourcing and needs to be embedded through the process, and we're probably struggling a little bit with that embedding through the process, but I think we're getting better, but it has taken 12 months to get to that point. And because I've raced through all of this, there is a 2-day sort of conference information session about whole of system change. This is going to be hosted by Streamliners and the Hunter New England Health Pathways team, and it's on here in Sydney on the 1st and 2nd of November for people who want to find out more.
Thanks, Margaret. There are flyers available if anyone's interested in that conference outside of the registration on the ACI desk, I think. The other thing just to mention is that Carolyn's kindly agreed to meet with some of the senior LHD managers, executives between 4 and 5 this afternoon to talk about measurement of ambulatory care services. So if anyone's interested, that's going to be in room 7ABC. But thank you very, very much, Carolyn and Margaret.
Thanks, Tracy and the team. It was interesting to see the collaboration and teamwork flows through to the colour coordination in the outfits. I'm very impressed. Do we have any quick questions from the audience in relation to the presentation? It's amazing to see the contrast between the two presentations we've heard so far, a whole of system approach to integrating care. We've got a question up the back. Would you like to make your way to the microphone?
Good morning. Morag Morrison from Health Consumers New South Wales. Put my glasses on, I can't see. I'm just interested in what the improvements in patient satisfaction and patient outcomes in your populations has been as a result of your new pathways. Thank you.
Okay, thank you. There's a number of things that we use to measure that. We use a process called EQ5D, which actually looks at people's view of their health status at the beginning of the process and at the end, and that's enabled us to test to see if new pathways actually work better. The other thing that we do, of course, is actually look at the function of the pathway and make sure that, in fact, what we are actually doing is shortening the time that people waste waiting to get to the right answer. In just 4 pathways alone that we've tested, we've saved 1.5 million days of wasted time for consumers. And we have consumers involved in a lot of our groups. So most of our service level alliances and most of our pathway processes have consumers. And as we've developed health info, consumers have been part of driving that entire process.
Okay, so very impressive. Thank you very much for the presentation. Would you join me in thanking the team who presented on the health pathways?